All right, we're a couple minutes after 3 here, so we'll go ahead and get started. Good afternoon. I want to welcome everyone to today's University of Minnesota COVID-19 Analytics Symposium. I'm Kim Choik. I'm the Program Administrator for the Medical Industry Leadership Institute, or MILI, at the Carlson School of Management. This symposium is organized through collaboration with MILI, the Management Information Systems Research Center at Carlson, and the Center for Nursing Informatics. On behalf of these 3 centers, I want to thank you all for joining us today. The purpose of today's symposium is to highlight a small sample of the many COVID-19 related studies and research occurring throughout the university and among industry partners. Today, we are joined by Pinar Krachamandic, Academic Director of MILI, Professor in the Department of Finance at Carlson, and is one of the team leads on the COVID-19 Hospitalization Tracking Project. Robin Austin is an assistant professor at the School of Nursing and co-author of Examining Community Social Determinants of Health and Resilience During the COVID-19 Pandemic. Jeff Clement is a PhD student at the Carlson School who will be discussing his research on disparities in continuity of care and access to medications during the COVID-19 global pandemic. Helen Parsons is an associate professor in the School of Public Health and co-author of Impact of COVID-19 on Cancer Patients and Oncology Physicians, results from a national survey. We also have Kartik Iyengar, Ram Rajagopalan, and Anthony Lang from Virtusa to discuss their research on eliminating bias in machine learning algorithms. Each speaker will present on their research for about 10 minutes, followed by 5 minutes for audience questions. If you do have questions during a presentation, please use the Q&A chat function in Zoom. And then to begin, I will turn it over to Professor Krachamandic to discuss an overview, findings, and trends of the COVID-19 Hospitalization Tracking Project.
Thank you so much, Kim. Thank you, everyone, for having us, and such a blessing to have this conference. So I'll try to give you a quick overview, a little bit of a rushed overview of everything that has been kind of keeping us at night since March. And so this is our hospitalization tracking project that we do at the Carlson School. Sorry. Kim, maybe let's just switch to you sharing my screen because I'm having difficulty advancing my slides.
Okay. All right.
Oh, thank you so much. We can go to the next slide. Yeah, so this is a project that is that started in March, really with an awakening for us that there was really not much data out there when it came to hospitalizations. We were getting a lot of data on cases and deaths, but we knew very little about hospitalizations. So that's our hospitalization tracking website. And when we launched this project, basically Soumya, my colleague here, who's the director of the MIS Research Center, and Raquel Giorgio, who's an executive in residence, next slide, Kim, with the Medical Industry Leadership Institute, we just kind of got together and we're like, we need to do something, we need to get some data together. And we were so fortunate to put together a team that has contributed days and nights to our data collection effort. So a big team and a growing team. I would love to acknowledge Yizu, who helped us launch this website literally over a weekend. Kim, who has been instrumental in our data collection and data organization efforts. Kualu, a PhD student in applied economics. Alex Everhart, very instrumental at the launch. And Zeming Lian, who has been working with us, especially in the sub-state data. And we have a wonderful team of undergraduate research assistants who continually work with us to do a very methodological data collection effort. Next slide, please. So what we basically do is we go every day, multiple times to every single state, multiple state websites that are sponsored by their Department of Health or governor's websites, all official sources. We collect all this data, then we put all this data in our database, and then we provide some additional data to facilitate some visualization analytics. And then that we extract the database into this interactive dashboard, which we then release publicly. And so we have a lot of steps that you can imagine, an effort that takes into account, all the different data times and queries, etc. But basically, our data refreshes as soon as we have data available, and every day we add more data to this website. Next slide, please. So the very early works we did, as I mentioned, going back to March, there were only 23 states reporting any data on hospitalization metric. And again, we thought this was so important to have data on hospitalizations, as well as the data on cases are and were. Testing was never made available on a comprehensive basis. It was not wide scale, it was very select. So we could not figure out a good denominator and a good prevalence of the disease just by looking at the cases. Deaths, the mortality related to COVID-19, of course, a very important metric. However, it basically is a very lagged indicator. So we wanted to figure out something in the middle, which is really important in terms of hospital capacity and planning and like really this flattening the curve so that we don't hit capacity constraints arguments. Happy to report as of October 5 and today too, October 7, all states are reporting some sort of hospitalization data. On different kinds of metrics, but some sort of hospitalization data. And very also interestingly, one thing that we do and we release some part of the data on the dashboard is we also collect, as much as states release it publicly, data in sub-state geographies, for example, at the county level. Again, almost no data in March, April, really beginning like mid-April, we started seeing more of that. And currently we collect these sub-state data from 21 states. Next slide, please. This just to give you a run through very quickly, an overview. The type of data we collect and report are total hospitalizations to date. So 38 states make that available. So that's basically cumulative to today. How many hospitalizations, COVID-19 hospitalizations did we have? Total ICU to date, fewer states report that. Most common is current hospitalization. So these are how many patients are in the hospitals today currently due to COVID-19. And states vary a little bit on whether they report suspected or current cases. And that's a little bit of a struggle, I have to admit. But we have 46 states. Minnesota and Alaska and Idaho recently stopped reporting this. And we are working with at least Minnesota really effectively. Hopefully this data will be restored back very soon. We also collect data on the very critical patients. So some states report this as currently in ICU. Some report it as currently in intubated cases or critical care cases. So we kind of like report all of those as more critical cases. And then very interestingly, a lot of states are reporting 25 at this point on currently on ventilator. Then there are other data elements that states report that we don't necessarily put out from our dashboard, but that we collect every day. So some states report their hospital capacity. So this would be, for example, their ICU beds, total beds, and not just for COVID-19, but overall. And that becomes important because hospitals, especially earlier or the peak times of the pandemic, have been adding beds. So we actually see numbers changing as states report higher number of beds, for example. Hospitalization breakdown by age, 23 states report that, and that's important in terms of figuring out it's the segments of the population, like the elderly or the pediatrics, and how the trends are changing. By gender, hospitalizations by race and ethnicity, only 14 states report, and we actually wrote about it, that we wish more states are reporting this data to really understand the vulnerabilities that is caused by the pandemic. And then again, 21 states are reporting some sort of data by county or region. Next slide, please. I'll actually skip this next slide. That's sort of, if we'll post these available on the web, that's sort of like looking at different types of hospital capacity metrics that we've been collecting. Next slide. So just to give you like visualizations, I don't have time in this 10-minute presentation, but if you log into our website, you will see these different tabs: current hospitalizations, hospitalizations to date, currently ICU, so all those different metrics that we collect, as I mentioned. So that's like a snapshot on current hospitalization. So what we do is we give you the snapshot of the day in a visual map version, but then what is really important is not just the total count, but really sort of a population adjusted rate. So if you look at the top right, you will see that you can select any states as you want. So here I selected Iowa, Wisconsin, Minnesota for Midwest. As you can see, these are current hospitalizations per capita. The green line there is Minnesota, as you can see, where the data collection ended on September 23rd was the last day that the state reported this data. Wisconsin and Iowa continue to report it. As you can see, the alarming pikes in Wisconsin and Iowa in terms of the increase in hospitalizations per capita. So we're hoping to get this data from the state soon. The other thing we show is from a static measure of sort of number of hospital beds or number of ICU beds, you know, sort of similarly that we do for the ICU visualizations, we can also normalize these numbers we have by per capita, but as well as per bed. So you can see here the capacity and how it is changing over time in terms of time and across states. And again, that's something you can select any state you want, anything you want. And you can see it has reached out to like 40%. And these are just COVID-19 hospitalizations. And those gray lines are like New Jersey, New York. But overall, that number tends to loom around like 20% of the hospital beds are typically occupied, you know, by COVID hospitalizations. Next slide, please. And here is a visualization of sort of the sub-state data, and this is a snapshot, as I mentioned. So this is a current hospitalizations. As you can see, not many states report these sub-state data, and the states that report vary in their reporting. California reports for every single county, but then if you look at Texas, bigger areas, for example, Michigan, similarly bigger areas, Wisconsin, bigger areas. So states usually aggregate their numbers, mainly for protection of privacy reasons, to larger bins. So in Texas, what we collect is something called trauma areas. So by different trauma areas, what is the rates are like. Next, please. And this is another way to look at the sub-state data, which is hospitalizations to date. Again, states don't really overlap in reporting both. So we use these for different studies and purposes. For some of them, we may use the current data. For some of them, we may use the cumulative data. And again, but the same idea, Florida, as you can see, tiny, tiny. So those are county level reports of hospitalizations to date. Whereas if you look at some of the other states, or like Washington State, like you have these bigger regions. Next slide, please. And this is some sort of like a representation of the type of publication we've had. This is just a select sample. If you're interested, please look at our website. And we've had quite a bit of a media attention, and we've worked with media very directly in in producing and helping them produce their stories, providing them data. So we've done a lot of custom data to Wall Street Journal, custom data to New York Times, and Axios. So these sites have basically used our data to do their own analyses, and I'm so happy, like we made it to the New York Times front page with our sub-state data, where they were looking at the big areas that were hit the most. I'll give you like a little flavor of the type of work we did. So the first paper that we wrote, next slide please, where we looked at sort of, this was very, very early data, some of the earliest data that we collected from this project, where we looked at the stay-at-home orders and how they were changing among the states. We could find only 4 states to do this analysis because we had enough data prior to their stay-at-home order. And we basically follow these states 12 days after their stay-at-home order was established. So the idea is like it takes about 7 days from infections to symptom, the median number, and then 5 days from symptom to being hospitalized. So we fit this very descriptive paper, very simple paper, and it was done on Excel, honestly, where we basically fit an exponential curve, and we identified exponential was the best fit across different alternative specifications, where we saw that basically that exponential curve, as you can see in the orange with the 95% bands, this is what we would have expected with the data, but then you can see the actual deviation from that exponential when we were looking at the actual data after the stay-at-home order. 12 days after the stay-at-home order, these trends that we started seeing significantly differed from what the exponential would have predicted in the absence of the stay-at-home order. Again, not a perfect study. We couldn't have any counterfactuals. We have a few that we presented elsewhere, but yeah, that's basically the first thing we looked at. Second slide, please. The other thing we looked at was, a lot of the model, a lot of the ideas around, well, You don't want to overload the hospitals, because if you overload the hospitals, you are going to have capacity constraints. But at the same time, understanding the severity of the disease, typically people are very severe. They make it to the hospital first, then to the ICU, and then unfortunately, some of these people die. And a lot of the modeling and the projections have to assume something about those linkages and the parameters. So in this study, we used our data from 23 states, March to June, and we looked at the relationship between number of people in hospitals today in ICU and hospitals in the non-ICU, and deaths. And we estimated this relationship empirically. And when we found that the 1% percentage point increase in the ICU bed use, which corresponded to about like 17 extra people in the ICU, was associated with almost 3 new deaths within the next 7 days. Similarly, an association with the non-ICU is a slightly smaller association, statistically significant, but also that makes sense. So that's basically, we did this study as like an important input in the modeling. Next slide, please. Another thing that we looked at was, we were hearing a lot about, racial and ethnic disparities from data coming from deaths and as well as infection rates, seeing, a lot of the minority populations are disproportionately affected. Nobody had looked at the hospitalizations before. So that's basically using, at that point, until June 24, we had data from 12 states. Now we have from 14. We have more to go. But basically what we looked at was, we looked at each of these states and we looked at the racial ethnic breakdown. And then we figured out and compared, really, again, a very descriptive study, how does this representation in the share of hospitals relate to that particular racial ethnic group's representation in the state population? In all of the 12 states we looked at, we found that whites represented a significantly lower share of the hospitalizations relative to their corresponding share in the hospitalization on the state, I'm sorry. And the exact opposite was for the Black communities, where we saw that a significantly higher share of hospitalizations relative to their share in the state. And very much the same thing for Hispanics in 10 out of the 12 states. And we also found some mixed but substantial disparity on 4 of the states, like Arizona and Utah, in American Indian and Alaska Native populations. So again, descriptive study, but really important policy impact as to how we can address these disparities in COVID-19 impact across communities in terms of both preventing infections, but at the same time increasing resources in some more targeted ways. Next slide, please. Other work that we're doing, I'm not able to share because some of the work is under embargo as well as some of the work is under review. We're looking at, as states reopen their economies, how are these outcomes that we care for, hospitalizations, ICUs, and the ventilator use, how are they impacted? Again, you can think of that study as like another important modeling parameter and an input where, as the economy opens up, what do we expect in terms of increases in these important healthcare metrics? We're also looking at age group impact. In this one paper, we're looking at the impact on pediatrics population and changes over time in the pediatrics population. Again, very important as we have the schools opening up and we're moving into the winter season. We're looking at rural-urban disparities. And finally, the other thing I want to mention is on July 15, an important change was made. Our data comes from state dashboards. And at the same time, CDC was reporting this data in a sort of a weekly updated way. But the Trump administration basically changed the reporting from CDC to HHS on July 15. So everyone got concerned about it. And of course we did too, because now we have these data coming from states. Now the data shifted from, CDC to HHS, lots of different questions. So I just also want to report here that we've been working on that. We've been looking at that data, reconciling the data, and we are in collaboration through weekly meetings with a working group from HHS, Department of Health and Human Services, as we make adjustments and understanding of the data that they receive and the data that we receive. And we've learned a lot. For example, one thing that we learned is the differences between suspected cases and the confirmed cases make a huge difference. So initially, HHS used to report just the overall suspected and confirmed cases, but through our idea of like we're mismatching the numbers, because in the state data, what we observed for a handful of states, we observed both the confirmed and suspected cases in hospitals. What we noticed is that that difference makes up a lot of the data discrepancy. So based on that feedback here in this slide, you basically see that in a lot of the states, if we actually incorporate the suspected cases, we see fairly similar numbers up to 1% match, 100% match to the HHS numbers. Not perfect. There are a lot of differences in the way hospitalizations are defined by hospitals and states. But based on this input, HHS revised their reporting, and now they're reporting both the suspected and the confirmed cases. So I see that as, something that we, try to contribute to the policy. And here, for some of these states that I report on, oh, I'm sorry, could you do a slide check, Kim, please? Yeah, so this is the slide where I'm talking about where the red lines are suspected and confirmed cases, whereas the blue lines are just the confirmed cases where our numbers, the blue numbers, mismatch to the HHS numbers. The one is the sort of the HHS number, but once we add in the suspected cases, we get some really close numbers. And next slide, please. And this is some of the select number of states that report both the only the confirmed cases, and these are our confirmed cases matching very well. Now that HHS has made the change of reporting confirmed and suspected, we actually have very, very close numbers. So that's really encouraging news. Next slide, please. We can advance this slide too. And I think I'll end there and ask if you open to questions. And sorry I rushed through it, but feel free to reach out to me anytime.
We do have a question, Pinar, asking, are you integrating any analyses based upon zip codes?
We are not able to integrate any analyses based on zip codes because, as I mentioned, just a handful of states, 20 states report anything in the sub-state level, meaning like in a geography smaller than a state, and even within them, only about 10 of them report at the county level. So we can't go anything below a county.
All right. It looks like there aren't any other questions, so thank you very much.
Thank you.
All right, next up, we have Professor Robin Austin from the School of Nursing.
Great, I'll go ahead and share my screen. And let me start the present mode, slideshow. Okay, great. Hopefully everybody can see this. Thank you so much for having me today for this symposium. It's been really great and an honor to be here. Again, my name is Robin Austin. I'm an assistant professor from the School of Nursing. And this project is looking at examining community social determinants of health and resilience during COVID-19 pandemic. So our acknowledgements here, I don't know why that turned upside down, my apologies. Our acknowledgements of, we have several funding sources that we worked with, and somehow my co-investigators got cut off here, so I apologize for that. But definitely thank you, this does not happen, this is definitely a team effort is what I wanted to say. So looking at, and it's mentioned before in the previous presentation around social determinants of health, certainly this has been very impactful for COVID-19. So now more than ever, we have vast volumes of whole person data that really need to be examined quickly to identify trends and point to next steps, as we've certainly there's fast moving data, as we just realized as well from the previous presenter around COVID-19, and this project specifically looked around social determinants of health and also resilience in our community, and we'll be able to show that in just a moment. So how did we do that? Using a data-driven approach, we used a system called the Omaha System, and if you're not familiar with this, this is a multidisciplinary standardized health terminology that is simple, it's recognizable, it's taxonomic, it's also in the public domain. Just a few things to point out around this slide is really the Omaha System was the foundation for us using the data that is standardized in a clinical form and also in a community form, which we will show. But really, if you're understanding the Omaha System, there are three main things to look at: is the problem classification scheme, intervention scheme, and also the problems rating scale focusing around 42 problems or health concepts that really describe all of health and healthcare. And what is really I wanted to point out is these 42 problems are categorized around 4 domains of health. So we have the environmental domain, which is where you live, where you work, things like that. The psychosocial domain, your mental health challenges, some of the other psycho components that happen with health as well, physiological, and also our health-related behaviors. And the Omaha system is also used in electronic health records, standardized evidence-based guidelines, and also in research. And we've been looking at using the Omaha system to describe whole person health, and also social determinants of health, as well as resilience. And I'll point those components out as we go through. But also this data is a collaborative of community of practice, other institutions that use the Omaha system for documentation. Certainly we share data and developed our community of practice that way. What I also wanted to point out, so is the Omaha system is a health terminology used by healthcare providers and professionals, nurses, physicians, very multidisciplinary use of this. But also we wanted to look at it from a community perspective and how could we have community identify in a way that is also standardized, achieving community and clinical interoperability. So we took what was on the left-hand side here, we see the terms that are abnormal, more kind of health jargon words, so to speak. But then how do we make that into a user-friendly, plain language that's identifiable and accessible by all? And so we did that, and we've named it the Simplified Omaha System Terms. And we looked at the Omaha system and did a readability assessment, and it's about the 16th grade reading level. And that the Simplified Omaha System Terms is about a 5th grade reading level. And we'll show you more examples of that. But just to put things into context of how we were collecting this data and the framework behind the data as well being standardized. So we use a data collection tool for the community data called My Strengths, My Health. And it is an application that was created by myself and Dr. Karen Munson, who is on the call as well. And My Strengths, My Health is free for clinicians, educators, and researchers. As we said, it is based on the Omaha system, the standardized terminology, put into consumer plain language terms. And we did have these terms validated by the community. We went out and had a focus group with community members to say, do these terms, what do they mean to you? Do they match with what you were thinking? And great conversation and dialogue to have those, the terminology vetted directly into the community. And again, it is comprehensive and holistic. We do look at across the spectrum of health, not just physiological or signs and symptoms someone may have, but also where they live, and also their health-related behaviors as well. And for those that have a, as we said, it's free to use, but you have to have a license in order to use it. So those that have their own license, you get a data, are able to download the data. Also, we have a dashboard, as you can see over here on the right-hand side. It says submissions about 150. Gives you an average consumer rating. The top consumer need will give you the top strengths and also top health challenges. We do have My Strengths, My Health available in Spanish, and Mandarin is coming soon, as well as additional other languages, hopefully by the end of the year. So here's a mobile, a tablet, and a PC view. So we said the app it's a web-based mobile enhanced application. So we have a mobile version or a tablet and also a PC version. And you can see we have the Simplified Omaha System domains and concepts. And before we had talked about those 4 main kind of buckets, so to speak, that organize the Omaha system, and we've renamed them into simplified terms. So we have My Living, which is the environmental domain, My Mind and Network, psychosocial, My Body is physiological, and My Self-Care is health-related behaviors. And these terms down here are the concepts in the application. And again, there's 42 total, and we'll get to more into detail on that in a couple of slides as well. So the basis of our project was really to look at whole person health, and whole person health is the ability, it's a person-centered way of leveraging not only leveraging strengths, but also looking at the individual's challenges and potential health needs that they may have. And within My Strengths, My Health and the Omaha system, we're able to actually look at specific components or those concepts related to social determinants of health. So within the environmental or My Living domain, we have 4 concepts that are directly related to that. Psychosocial or My Mind and Networks, we have 12. And then health-related behaviors or My Self-Care are 8 specific concepts. And how we look at resilience or strengths within the application is that we look at it on a scale, a status score of 4, meaning minimal signs or symptoms, or good in my strengths, my health, and a 5, meaning there's no signs or symptoms, and a very good in my strengths, my health as well. So what we're trying to look at is looking at equivalent interoperable whole person data, not only from My Strengths, My Health, a community perspective, but also through the Omaha System data partnership. This allowed for parallel investigation of whole person health that looks at including also social determinants of health and resilience for individuals and populations. So we have on the left-hand side, the Omaha System, social determinants of health here in the middle, and also My Strengths, My Health on the right-hand side. So we'll get into the specifics of the data. So our purpose was to explore resilience in the context of whole person health and social determinants of health from the individual community levels using large standardized nursing data sets. This is a retrospective observational correlational study using de-identified compliant data that's a framework of the Omaha System and equivalents of the simplified Omaha System terms. Our aims of the study were to calculate percentages of problem concepts rated as a strength, meaning it is greater than 3 on a 5-point scale, and among all who rated a problem concept that identified frequently as strengths. And we also analyzed the strengths in a correlational matrix by problem, which we will see, and we used a heat maps to visualize the patterns related to the correlations of the resilience across the problems. And then also we examined assessment patterns within My Strengths, My Health and clinical data. And this was a finding that we kind of discovered as we went through and were analyzing the data as a way to being able to assess when a problem is being assessed by a healthcare provider, is it also identified as a strength, and we'll show that as well. Our methods that we used, we had 3 samples of to explore for patterns of resilience. We had 3 different data sets. We had a pre-COVID-19 data set, which was community generated and 383 participants, a pre-COVID clinical documentation data set with over 50,000 participants, and then during COVID, which is currently still in progress as well, right now community generated data, 102 participants. And so the community data, as I think I mentioned before, was from My Strengths, My Health app. And then the clinical data was from our Omaha System Data Collaborative. And I think I mentioned before, we operationalized resilience with the scores of 4 or 5 and with around the 42 problem concepts. And then we used data visualization techniques using standardized or standard descriptive and inferential statistics. And so I'll get right into the results as well. So for AIM 1, we realized across all 3 data sets, we had many strengths that were recognized across all 3. As you can see, the percentages here of 77% for the community data, and then 68% for the clinical data, and 64% for the COVID-19 reported data for strengths as well, But what I wanted to point out was the difference in comparing the pre-COVID-19 to the during COVID-19 data is there was a significant drop in strengths, what was reported as a strength from the community. So you can see here this column that says community here, and then the COVID-19 here, we had a significant drop related to income and social contact, which would be expected given the times of that we were in shutdown as well. And some other changes were around caretaking and parenting. Certainly that took a major shift within our daily lives, as well as some of the health-related behaviors that we can see down here. And it should be noted that these may look a little bit different, the community data versus the COVID-19 data. For the community and the clinical data, we had all 42 concepts within the Omaha System, but our COVID-19 community outreach, we decided to go with about 20 concepts versus the full 42 to directly narrow in on some of those health topics that were more prevalent during this specific time as well. And then it should also be noted that across these data sets, about a 75% threshold, neighborhood, workplace, and safety, abuse, and community infectious diseases were all reported as strengths across. And reporting abuse as a strength, meaning it's not happening. So that was a good thing. And results of AIM 2, this is looking at our data sets across the 3 data sets to identify resilience patterns. And what really emerged was we had the communication with community resources, or it's also called connecting in our My Strengths, My Health app, was that we uniquely related with strengths. So if someone identified communication with community resources or connecting as a strength, it was highly correlated with many, many other strengths. And so this is really quite actionable in understanding what's happening in our communities, that if you have a strength in community or your connection to community is very strong, you're more likely to have other strengths going on with your overall health and well-being as well. This pattern was not found within our clinical data, but we did find another unique strengths pattern within our clinical data was around sleep and rest in the Omaha System, or sleep in My Strengths, My Health, that if someone indicated they had a strength in sleep or sleeping patterns, that this was highly correlated with other overall strengths as well within their health and wellness. And the more we understand about sleep hygiene and the importance of sleep, that also seems to make sense as well, but certainly more work needs to be done around this area, more research. Our third aim is looking at the documentation variability between community and clinical data. And so really we're looking at the top graph here is that the concepts assessed between My Strengths, My Health and the clinical documentation differed greatly. The blue line is the community data and the orange line is our clinical data. And then despite the high percentages of strengths that we had shown overall as well between community and the clinical documentation, there's still percentages of different between the two as well. In the bottom graph, which is what was really quite interesting, was that when percentages of overall assessment were completed, when each concept was assessed by a strength. So using strengths as a basis for asking around health problems seemed to be more of an ability to identify additional ways of identifying strengths across a comprehensive wellness. So really this gives us the ability to look at things from a comprehensive perspective and potentially understand how we could shift that perspective from a deficit or a problem-based to more of a strengths-based approach. If we ask more about strengths, we're more likely to get more about strengths as compared to looking at things from a different perspective or angle. So our discussion and implications is that we definitely found a feasibility to examine resilience when we operationalized as a strength by problem within existing Omaha System and My Strengths, My Health data sets. And certainly the communication with community resources pattern was correlated with strengths and was consistent across community data sets, which this also suggests that Omaha System assessments may differ in simple yet meaningful measures of resilience when this is assessed as a problem, but really that is an actionable item that we could really identify, being able to really say that community is really a basis for health and wellness, and that it's really associated with resilience within community. And that findings have demonstrated that the Omaha System within My Strengths, My Health could be used consistently by consumers for a whole person assessment. And that really this could reveal valuable insights for resilience at the population level. Being that our data is generated by the community, that it's been consistently used in multiple different areas and different ways of collecting the data. So more to come on that as well. And that looking at the notion of how we assess individuals and communities, that is the completeness of our assessments in relationship to the whole person health, really determines what we can know about resilience. And again, that points back to when we're asking about strengths and we're asking about resilience, we seem to get a broader perspective of what's happening specifically with that individual and also the community level as well. And our conclusions, we demonstrated that the value of standardized assessments across communities and clinical settings over time, which is pre-COVID and also now during COVID, which is again still ongoing, is really a basis for understanding patterns of resilience. And we have findings that are emphasizing the importance of resilience in the way that we work with communities to address the challenges that we're facing in extreme circumstances. So really understanding how communities use resilience, especially during this time of extreme circumstances, has been really a quite valuable insight. And that truly the paradigm shift that we look at from one of resilience is truly long overdue. So therefore, we're really trying to move this work forward. And so I will pause there and see if there are additional questions. Oh, and I have, here's my contact information. And if you're interested in more about My Strengths, My Health as well, we have, hopefully the QR code will work as well. I tested it, so hopefully it will be working, but I'll take questions as well.
So we do have a couple questions just asking maybe for a little more clarification.
Sure.
The first one is clarifying that the data sets are independent and that you have no longitudinal data using any one survey tool. Is that correct?
Correct. They are independent data sets. Yes. So,
Okay.
but the community data are generated by My Strengths, My Health, but they were separate, not the same individuals.
Okay. And then the second question is just asking for some clarification on your definition of strength.
Sure. Yeah. Great question. So we talk about strengths are also as assets, as a person's ability to bounce back or to have perseverance through health challenge, specifically around health, around these health challenges, and to be able to persevere through them.
All right. One more question is this a model that you think could be relevant to the employer group setting?
Yeah, that's a great question. I certainly think so. That's a really, I think I'm stumbling over my words because I have so many thoughts at the moment, but certainly I think knowing that we know about well-being and the strengths and resilience of our healthcare workers right now, we knew that caring for the caregiver is always a big deal, and how burnout around healthcare providers is a big deal. Around COVID, it's becoming more of a big deal. So I certainly think that this could be a model for that. I'd be anxious to look at that and how we could use it in an employee situation. Absolutely.
All right, wonderful. Well, thank you. Are there any final questions for Professor Austin? All right, I think that will do it. Well, thank you so much.
Great, thank you.
All right, next up, we have Jeff Clement, who's a PhD candidate at the Carlson School of Management.
All right, thank you so much. And let me share my screen. There we go. All right. All right, yeah, thank you, everybody. I was gonna say that this is the first time I've put on a tie in a while, but then I chose not to put on a tie. So this is a joint work with Brad Greenwood at George Mason, and we're looking at drug utilization and access during the COVID-19 pandemic, in particular disparities. And so the question that really prompted this was to ask, what happened to everybody who was taking some kind of medication or needed some kind of medication during the COVID-19 pandemic, unrelated to COVID-19. And so, you know, initially, like, you might think that, like, well, of course, everything is going to get disrupted. And that was sort of our gut feeling. But we, you know, then we started to read more. And so, like, this is one that's really striking to me. You know, this is about physical therapy, which, you know, traditionally takes place in a clinic, and you go and they have all the exercise equipment. And even physical therapy has transitioned to a virtual model. And in fact, they've seen some benefits that they're actually able to see patients in their own home. And so then that really made us reconsider our initial hypothesis that, you know, everybody's going to be disrupted, and we're going to see, you know, widespread issues with access to medications. But there is a lot of evidence that things were disrupted. You know, I think all of us can point to things in our own lives where there were major disruptions. And so this is from a recent NBER paper showing that short-run access to outpatient care was widely affected. There's as much as a 40% decline in outpatient visits starting in March. You know, and it's not just tracking closure orders. So a lot of it is driven by either the clinics reducing access, not wanting people in the clinics, patients choosing to stay home, those kinds of things. This paper identified some interesting differences in different specialties, and in particular mental health was less affected than some other specialties, which was encouraging and really drove our desire to really dig into this further. And particular that there was a lot of substitution by telehealth, so that it seems like, well, maybe people are still able to get access to their medications. And so this sets up a situation where the actual impacts to medication access are really not clear. So on the one hand, we do have all these massive forces that are driving non-adherence and potentially interrupting a patient's access to their medication. the financial strain, just the stress of COVID, loss of employment, public transit potentially shutting down, pharmacies, closing, health facilities closing, doctors not taking appointments, the stay-at-home orders, all those kinds of things. But then on the other hand, there are a number of forces that are really helping to support patients with continuity. So when you're given a prescription with a year's worth of refills, you really may not be that affected. Many pharmacies are pushing for larger fills and dispensing medication by mail. Especially on the specialty pharmacy side, which is convenient for patients, it's cheaper, and then finally telehealth visits. So it really sets up this situation where we really didn't know what was going to happen, what we were going to see. So the first place we looked was at sort of data in the aggregate, and I should say that please dump questions in the Q&A, because this is still pretty early stage work, and anything that you're curious in, I'm sure other people will be curious in, and we'd love to see what people think of this and where else we should look. But so we started looking in the aggregate, and so this data is nationwide. It's from Symphony, which is a insurance claim clearinghouse. So when the insurance claims come in from the pharmacy, rather than the pharmacy directly sending the insurance claim to Blue Cross Blue Shield or United or one of the other insurance companies, they will send the claims, they'll send all of their claims to the clearinghouse, and then the clearinghouse will handle the coordination of benefits. If somebody has more than one insurance company, they handle any copay benefit cards from the pharmaceutical company, and all that. So this data is a pretty good comprehensive view of the US. It's not everybody, but it's probably somewhere in the neighborhood of 60 to 70% of the universe of claims. So this is a pretty good snapshot of what's going on in the aggregate, but it's not down to the patient level. All we have is basically at the month level. So this was one of the first ones that we looked at. So this is the number of prescription claims per month across the US. Again, not all of them, but it's something like 60 to 70%. So it's a very good representation of what's actually going on. And we can see that here in March, there's a huge jump in claims for Crestor. And the dots are what we would forecast based on standard like time series ARIMA model. So we see what we would expect, and then there's this huge jump higher than more claims than have ever been seen in a month for Crestor. And then when you look at between that March to June time period, essentially it's right in line. The total number of prescription claims are exactly in line with the forecast. And so we were really surprised to see that people were able to stock up. So in the aggregate, it doesn't look like many people had to go without their statins. So that's good, obviously. We saw a very similar effect for Metformin, which is used to help control diabetes. So again, same type of model, and we see that people stocked up more claims in March 2020 than have ever been claimed before. The noisiness of this data is not a mistake. In case anybody's wondering, I used to work in pharma, and we do see this kind of seasonality in pharmaceutical claims. So that is not really terribly surprising, and we wouldn't expect to see a flat line, but this huge jump is notable. So the first couple drugs, we looked at and we're like, oh, everybody's stocked up, and maybe there's not much here. But as we dug further, we did start to see some interesting effects. So this is Follistim, which is used as part of IVF treatment. And we can see obviously just a huge drop that has rebounded somewhat, but much lower utilization than we would otherwise expect. So it does look like people essentially put off or delayed IVF procedures. And that drop, how significant is that in terms of like population health, delaying the birth of several thousand children potentially by a month or two, you know, that can be debated. But for other things, you know, I think there's much more significant potential health impacts. So this is the number of claims for ADHD, an ADHD medication called Focalin. You know, definitely debates about overprescription of these types of things, but you know, you can see that as soon as the pandemic hit, essentially people stopped filling their claims, stopped filling the prescriptions for Focalin. These dips here in the middle are interesting. So these every summer, and this data goes back about 10 years, every single summer there's a significant drop for all of the ADHD medications, which leads to some interesting questions like, you know, and we don't have the data to answer these, but, you know, are kids just thriving at home? Are parents not filling the medication? You know, what, you know, a lot of questions there. This is one that we found particularly interesting and is concerning to us. So Suboxone Buprenorphine is used to help treat withdrawal symptoms in patients with opioid addiction. So to help people overcome addiction. And we see a very significant decline. Overall prescriptions are down about 5% between March and June than they really should have otherwise been. And you know, that can have really significant consequences, because essentially if somebody was unable to access, you know, their medication, they may have then turned back to street drugs, or, you know, it could also indicate patients who were looking to start, you know, maybe looking to start overcoming an addiction and were not able to get access to medication. Similarly, birth control. So we do see that there was a significant drop in that April, May, June time period. And it was not accompanied by sort of that stock up that we saw with some other drugs in March. So, you know, again, this could have some, you know, pretty significant consequences for people, you know, if they, you know, contrary to maybe what they were looking for in terms of planning their life. So obviously, like, this leaves a lot to be desired in terms of, you know, really diving into specificity. So we took this data and approached a consortium that is working on some COVID-19 projects and helping researchers gain access. And we got access to essentially the near universe of health insurance claims. So literally billions of health insurance claims, so that we can start digging in a little further and looking at disparities between gender, geography, states, ethnicities, those types of things. And we are seeing some effects there, that the, you know, things like stocking up are not universally accessible to everybody. Unfortunately, I can't show that data today. It's currently embargoed, and we're working on getting that released for our paper. But we do feel pretty confident that it's going to show some interesting effects. So, for example, one of the drugs we're looking at is our class of antipsychotics from a sample of 8 million patients. So we got a really good sample size. And then we're also looking at you know, things that really have practical policy impacts for either the future of this pandemic or future events. Looking at, for example, the number of attempts to refill that were rejected. So, for example, code 79 is you go to the pharmacy and they say, sorry, we can't fill this because your insurance company says you should still have drugs. So we're looking at that, you know, people who tried to stock up in March and it was denied, or prior authorization rejections. You know, so that's an area where the payers could potentially adjust their policies and make some administrative shifts to, you know, make things easier on patients and ensure that they have access to their drugs, you know, during what is potentially a pretty difficult time. So with that, I will, I think, yeah, that's it. So I will pause there and stop my share and move to any questions.
We do have a couple comments.
Okay.
The first one is, while the patient, prescriber, and claims perspective is certainly important, it seems that a more significant impact on medication availability is probably related to medication source and supply chain, given the on-demand nature of most major drug wholesalers.
Yeah, so that's something I definitely agree with. And, we may or may not be able to see that in or sort of derive that is happening. I have spoken with a number of people in pharma, and during the pandemic. So, and I used to work for a number of pharmaceutical companies, and typically, like, our stock on hand might be between 3 to 6 months. So, yeah, like long term in the COVID-19 pandemic, you could definitely be running into supply chain issues, and other drugs are run much tighter. Some biologics, have pretty short expiration dates, so they can't manufacture a 2-year supply, for example. So yeah, I agree with that.
Okay. The next comment is that it makes sense that drug use related to elective activities would decline and be expected.
Yeah, and absolutely, and that's that one is one of the things that we checked kind of to make sure that that what we were looking at made sense. If we didn't see that decline, that would really lead us to question this method. Because if we did not see a decline in people pursuing IVF, or at least delaying their IVF, everybody's life got disrupted in this, so if you didn't see at least some delay, we'd be really questioning whether or not this data and this type of analysis would actually reveal that people were not accessing, drugs that they needed.
Sure. Another question that came through is rejection based on early refills something you observe? And then follow up is, some insurers have implemented early refill as early as March.
Yeah, so we do see, in our data set, unfortunately what I showed you today, I can't show you the but the full data set that we do have does include both claims that were filled as well as all the claims that were rejected for various reasons. And the rejection codes it's a pretty good, it's like a 20-page document with all the lines of different rejection codes. So it goes into pretty good detail of why. So for example, with prior authorizations, it's not just rejected something to do with prior authorization. There's probably 15 or 20 different codes related to prior authorization. So you get a pretty good idea of, did they do the prior authorization and the paperwork was wrong? Did you submit a prior authorization for the wrong drug? Yeah, so we have pretty good visibility on that.
Wow, okay.
Yeah, so, and yeah, definitely some insurers implementing and assisting with those things, that's a good measure. But we still are seeing that there was an increase in the number of rejections for patients attempting to refill early in March. So it does look like there were patients who tried, and so part of our analysis we're looking at, did those patients then subsequently run out of drug?
Okay, we'll do one last question. It would be interesting to match drug use with death data to determine if any associations are observed. Is that anything that you have looked at?
We have not, and that's a really good suggestion. I would like to look at that, and I do think we have that in our panel, or could match it. It's de-identified, but we do have a tokenized patient ID that I think we could crosswalk that. So yeah, thank you for that suggestion. That's,
okay.
Yeah, something we'll look at.
Wonderful. Well, thank you so much, Jeff.
All right, thanks.
All right, next up we have Professor Helen Parsons from the School of Public Health.
All right. Well, thank you for having me today. And I will be presenting results from a national survey that we conducted looking at the impact of COVID-19 on oncology physicians. I have no personal financial disclosures, but our work was supported by a number of funding sources listed below. As a bit of background, we know that in the year 2020, an estimated 1.8 million new cancer cases will be diagnosed across the United States. And with the development of the COVID-19 pandemic, cancer care delivery has really transformed both the norms as well as the approaches to cancer care delivery that we've seen throughout the US. There's a number of approaches that have been taken to help stem the growth of COVID-19 in the context of care delivery, including the widespread adoption of telemedicine, particularly for cancer patients, the postponing and the canceling of non-essential procedures for these individuals, as well as the modification of treatment. However, as the COVID-19 pandemic grew, we have realized within our team that limited research on the initial impact of COVID-19 was really available to understand the impact on cancer care delivery. So the objective of the study that I'll be talking about today was to evaluate the initial impact of COVID-19 on individuals with cancer, as well as oncology physicians across the United States. To do this, we actually conducted two distinct surveys. We conducted one survey among oncology physicians, which I'll be focusing on today. We also conducted a separate survey in the general population that included a subset of cancer survivors, as well as those undergoing active cancer therapy. And I would be happy to discuss any of the results with those with individuals offline, so feel free to reach out to me. For the oncology physician survey specifically, this was a cross-sectional anonymous online survey that we conducted at the beginning of the pandemic. So we fielded the survey the last week in March through the first week and a half of April of this year. And we recruited oncology physicians through Facebook, Twitter, and LinkedIn methods. The survey information that we asked physicians to report on were their demographics, measures about their clinical practice, for example, where and how they practice and the type of institutions they practice, their reported concerns around COVID-19 and how this affected their treatment decision-making in the initial run-up of the pandemic. We also asked specific questions around their emotional well-being during that point in time. Of our respondents, we had 548 individuals who began our survey and 486 individuals who were eligible. And so these were individuals that were oncology providers that practice within the United States at the time of the survey. In terms of their demographics, they were on average 45 years old and had been in practice almost 13 years. So these were primarily mid-career oncologists. The majority of respondents were female and they were white, non-Hispanic for over 75% of respondents. We had a good representation across the oncology specialties with about 56% of surgeons who are our respondents, followed by medical oncologists, about 23%, radiation oncologists, and other specialties. We looked at a number of different outcomes, and I'll highlight a few of the publications that we've focused on so far. The first thing that we really asked about was their COVID exposure in this initial time period, as well as their concerns around the COVID-19 pandemic. Now, as you can see on the top, for the top question, while only about 20% considered themselves to be high risk, and we identified each of the characteristics that would, at that point in time, have put them in the high risk category. The vast majority were concerned about not only their own risk for contracting COVID, but also concerned about their patients getting COVID from them at 60 and 65%. Also in line with what we were seeing in other literature at the time, about 41% reported that they did not have adequate personal protective equipment within their practice. And they also had significant concerns about the availability of care should their patients become extremely ill from something other than COVID-19, which is very relevant to patients who are undergoing cancer treatment and are immune compromised during their course of therapy. Apart from understanding the concerns of oncology physicians, we also wanted to understand differences and changes that had been made to their cancer treatment plans for their patients. And so in the second study, we were able to look at identified changes to practice and the underlying reasons behind that. So we found that about 70%, or 282 of our respondents, reported that they had already made changes in their cancer treatment plans by the end of March, early April. And there were a varying number of reasons for why this happened. The most common reasons were personal concerns, as you can see on the top line, about their patients' risk for exposure. There were also, the majority of individuals wanted to, or desired to conserve personal protective equipment at their institution. They also had coupled this with divisional or departmental mandates or institutional mandates, as well as following professional or Surgeon General recommendations. And while we have others as well, those were the primary reasons. And to note here, they did vary by medical specialty. The next bucket of research outcomes that we looked at were around the well-being of physicians at this point in time. And these were surprising, I think, to our research team in a way that we found over 62% of oncology physicians reported being anxious at the time of survey. And factors that were associated with a higher likelihood of being anxious included younger age, being female, having less time in their clinical practice, practicing in states with higher COVID-19 case counts, and reporting that they had inadequate access to personal protective equipment. We also found in our analysis that individuals who reported anxiety were also moderately or extremely concerned about getting COVID or transmitting it, as well as their patients' access to the necessary level of care if they were to develop a serious illness during the pandemic. But it wasn't just anxiety that we identified as a challenge that oncology physicians reported. Over 23% of physicians within our sample also reported depression. And among those that were reporting depression, almost all of them reported anxiety symptoms. Individuals that were more likely to report depression included those who were identified as having Asian or Indian race, as well as those who had also reported interference with their ability to provide cancer care. Similar to our findings with anxiety, we also found that having depression meant that these individuals were more likely to be moderately or extremely concerned about getting or transmitting COVID, as well as feeling like their patients would have access to necessary medical care. And the final group of outcomes that we looked at was, now that we understood better about the initial treatment changes, underlying reasons for that, as well as the general well-being of physicians at this point in time, if we were thinking forward around how we might approach and get the best information out to them, what were the sources of information that they were using for COVID-19 to really understand practice patterns and guidelines? And what we found is not necessarily surprising, but is helpful thinking forward about policies and implementation going forward, in that the vast majority of respondents use their hospital or institutional policies or communications, in addition to professional society recommendations and guidelines, as well as the CDC. However, we also asked information about how much they trusted these sources. So we wanted to understand not only what they used, but how much they really trusted it when they were seeking out information. And we found that professional societies were by far the most trusted source of information. We do acknowledge a number of limitations with our survey, including the social media recruitment strategy, but we wanted to be able to identify physicians at that point in time as the pandemic was developing. We also had a larger percentage of surgeons and female respondents relative to the overall demographics of oncology physicians in the US. And we also note that there may be a social desirability bias that may have resulted in underreporting of some health behaviors such as anxiety or depression in the population. And so future work needs to be done looking at baseline rates of anxiety and depression because we don't have measures of their baseline levels prior to the pandemic. So in conclusion, in our study, we found that oncology physicians report significant concerns with COVID exposure for both themselves as well as their patients. And initially, in the early parts of the pandemic, this resulted in significant alterations of treatment practices across the United States. We also noted that there are high levels of anxiety and depression among oncology physicians at this point in time as the pandemic was developing. So we found some opportunities that there may be opportunities to utilize common sources of information for communication about COVID-19, its impact, and potentially even future interventions. Overall, it's going to be important to understand the impact of COVID-19 on care delivery as well as physician well-being into the future, as this will help us to understand practice patterns and opportunities for intervention going forward. I'd also like to acknowledge the entire team who really helped to make this a possibility across the academic health center from various oncology specialties. And with that, I would be happy to take any questions. Thank you.
All right, we have time for probably about one question. If anybody has any questions, feel free to enter it into the Q&A chat box. All right, it doesn't look like there's any questions.
Okay.
Well, thank you so much, Professor Parsons. We appreciate it. And lastly, we have the team from Virtusa, which consists of Kartik Iyengar, who's the CTO of Life Sciences, Ram Rajagopalan, who's the Senior Director of Medical Devices, and I don't know if Anthony Lang, who's the BU head of HLS, if he was able to join.
No, unfortunately.
Okay, well, that's great. You two can take it away.
All right, thanks, Kim. Thanks, MILI and School of Nursing, School of Public Health, for the opportunity here to present. It's great to be here as a ex-Carlson alum and a MILI member. It's great to be here with you guys. What we wanted to talk to you guys today about is, as we all go into the AI-driven world where artificial intelligence and machine learning algorithms are more and more getting entrenched into how care is being provided, there is something that we need to consider parallel to that, which is basically the bias that goes into building these algorithms and how do you prevent those from affecting equitable care to all. So that is going to be the topic of our discussion. I don't have a cool background like Helen did, but I can show a quick video to compensate for that, just for a few minutes.
I think we might have to skip the video because I don't suppose that it's audible.
Oh, okay. So let me go back to the presentation here. Sorry about that. Let me skip it. Okay. All right. So, bottom line, right? I mean, there's a lot of potential for AI in healthcare, but bias is something that we need to consider. You know, in the words of Elon Musk a few months ago, is basically, who's writing these algorithms? Will the negativity play a big role in how they impact healthcare? Some of the frequent problems encountered are underrepresentative data samples, high likelihood of model overfitting, and imprecise reporting of study populations in intended model use. So, the premise here is we need to go beyond just the utilitarian foundation and make sure that we don't avoid harming certain groups due to the disparities that we bring in. So a couple of concepts. Virtusa has worked pretty extensively in the field of artificial intelligence and bias elimination. And some of the concepts that we have really looked at in detail around data Shapley and multi-accuracy boost. Data Shapley is pretty brand new in the AI world. It started gaining prominence back in 2019. And this is around the premise that, how do you go about eliminating bad data points and corrupt data points from the data set. And then multi-accuracy boost is more successful in basically looking at understanding predictions about people and their behaviors and how you go about solving those things. So with those concepts, I'm going to kind of hand it off to Karthik for a quick overview and then a couple demos.
Sure. Thanks a lot, Ram. I'll just take a quick minute to explain the concept. So what we have is a platform which I want to show you a demo in terms of the applicability, that too in context with COVID-19, what we're living in, that too with respect to socioeconomic policies in terms of really containing the spread of the contagion pretty much. And the second thing is what we are really looking at is to make sure that when we're looking at the providers of the hospitals, how do we make sure that the hospital beds are available to everybody, agnostic of socioeconomic status, gender or ethnic background bias or race or gender bias. So that's what we would be looking at focusing on. So unfortunately, my screen share is disabled. Is there a way I can take over the screen? So rather than just looking at the, this particular slide.
Yes, you should be able to get access to that now.
Awesome. Thank you. So I am sharing my entire screen. So what I really, if you can see my screen. Screen
Not
share.
Yet.
Not yet. Okay. Ram, may I ask you to just request you to just go into the BeLife portal because I think I'm having challenges with this thing. While you do that, let me give you a quick overview about Data Shapley. What we are really looking at is we are bringing together the concept of Data Shapley and multi-accuracy. And in the meantime, I'll just give a quick idea about what Data Shapley is. In terms of training a machine learning algorithm for supervised learning, whether it is on a data set that's going to be comprised of structured data or or image data, what Data Shapley does is, in terms of every single element of the data record, it assigns a positive or a negative value for the processing, and that is something that we can set a value for in terms of the algorithm, saying that for a particular Shapley algorithm, if the data record is going to be a value that is positive, it's going to be impacting the training of the machine learning algorithm. For instance, if we are going to be training a machine learning algorithm on a record set of around, let's say, 1 million records, then not all the 1 million records in the data set are going to be having an impact on the training of the algorithm. So Shapley will assign a value that is positive or negative in terms of saying that which are the algorithms that will actually impact the training of the machine learning algorithm to reduce the bias in terms of making sure that we do more with less data. So that's Data Shapley.
Can you stop sharing so I can pull my screen up?
Sure. Thanks. So I don't even, I'm not sharing that.
Okay, all right, I think I'm good. All right.
Yeah, perfect. And in terms of multi-accuracy, pretty much what multi-accuracy does is, it's again a post-event process. If you can go into Stanford AI and click on the Shapley images, second one, the second application. So I want to show an example with images where we're using deep learning as an algorithm. Yeah, go ahead and try the demo. Take the sample data. So not specific to COVID-19, but this one is specific to 4 different images, few of the images, where we are taking out the matrix and looking at reading the data. If you can scroll down, Ram. So typically what we do is we have synthesized the data since the images were low. Come down, please, and use a base CNN model. Just use the base CNN model, and you can see the network. So what we've done is we've converted the image into a matrix as usual, and then measuring out typically what we do with bias, and click on the retrain with Shapley as well, Ram. So what we do is measure out the accuracy, the AUC, the precision, and recall. Now, what typically happens is the Shapley value will actually go ahead and say that I took 1 million records, I dumped it on my algorithm on top of it, and then took this out and trained my value of Shapley. Now I removed this, and as you can see, though this is an overfitted data set, for the purpose of the visualization, I got my algorithm getting trained better on the same. If you look at the AUC or the recall or the accuracy, it actually goes up. Typically, I would look at the accuracy. Right. This is the combination of a data set that's image driven, and the synthetic data was generated using GANs. So we kind of exponentially introduced the same amount of random noise into the data set and increased exponentially by, and made that data set so that we could actually have more images. So we anyways had a better trained model. Now, if you can go back, Ram, and click on Stanford AI. And there's a reason, everybody who's watching it, why we call it Stanford AI, because we're working this with Stanford AI laboratory. If you click on multi-accuracy, yeah, so this is what Ram was talking about. Click on the sample data. Now, here's a visualization very clearly specific in terms of the EMR records for the patients who are actually, we are looking at the ethnic population of the patients. Can you scroll down, please? Yeah, here's the details of the data set. One of the speakers talked about how, can you build the model also? Click on build the model, Ram. Click on build the model, while it'll take a few seconds to execute. So the data set actually comprises Asians, Black, Hispanic, Natives, others, and white. We want to make sure we kind of remove the bias so that anytime a patient with any of these ethnic backgrounds walks into a hospital, the patient is going to be provided the same amount of care and PPEs and hospital beds in the lack of the existing pandemic. So one of the applicability of the same is over there. Now, what it does is, it's a post-processing event. It looks in at the multiple clusters in terms of the pockets of what you have really had, and creates the kind of prediction that you do that over here. Look at the accuracy or the AUC for that matter, which is 97%. May I request you to click on retrain the share with multi-accuracy RAM and scroll down. So here what we are doing is we are taking the base comparison by taking in the contrastive model and comparing, and multi-accuracy boost works on, for example, if you use a classifier, for example, like a random forest or F0, to train everything out there in terms of multiple counties or states or ethnic groups, whatever be what Pinar actually showed about, for example, in the beginning, right? And even if you had an algorithm that pointed out specifically to zip code driven measurements, if that were possible, and assuming the fact that if you were to be applying county-based classifications over here, and then comparing one county to the other, saying that based upon contact tracing as an app, what has been the or potential of exposure to COVID-19 in terms of doing that, you would actually see post the multi-accuracy boost, you would actually see before multi-accuracy and after accuracy how we remove the bias from that, saying that the availability of beds, or it should be devoid of race. In this case, what you're seeing is just a race, but you can put a multitude of factors, so you can make it multidimensional into saying that I want to bring in race, I want to bring in ethnic backgrounds, I want to bring in community affiliations, and I want to bring in socioeconomic status or what have you, and then reduce this particular thing. Can I request you to click on Stanford AI one more time, please? And the last demo, which I want to show it to you in a minute, and look at the COVID-19 simulation. I want to show you what exactly we have worked out with one of the laboratories at Stanford, that's Hospitalization School of Engineering. If you look at the timing intervention and select a country, that is Italy, Ram, can you select a country? let me give you a brief background about data sets. What we've done is we've taken the data sets from multiple countries. And if you look at the strength of the intervention, increase the strength of intervention, please, Ram. And this is pretty much what we have been seeing on TV along with Dr. Fauci, and execute that, please, and do a simulation. So this is a simulation based on the socioeconomic factors, saying that had we responded better at the time of the outbreak. And Ram, can you also select all the 3 different elements on the right-hand side, please? Hospitalized, fatalities, and the total number of diagnosed cases. What we are doing is, in terms of flattening the curve, so how do we make sure that we flatten the curve had the uncertainty error being higher and the intervention of timing, had we stopped the flights coming in from Italy being acted upon earlier and the flights from Europe being acted upon earlier, and the strength of intervention in terms of lockdown, as well as intervening the diagnostic rate, we can play around with the simulation, which actually tells you that if we had a bigger data set that's exogenous in nature, and if we were to have a data that's going to be taking in details of contact tracing, how preventive can we be in terms of flattening the curve so that we can avoid the second wave from coming. I think in the interest of time, I would just leave it like that and request. And there's a GitHub project which we also started, and right now we've kept it private. But if you wish to learn more, you're very welcome to have a conversation with us, and we would love to work with you and share the code base with you. But I'm also not sharing what we call this is in terms of faster AI. We are also working on with contrastive PCA, which is actually taking multiple data set and using it as a contrast so that we kind of give our comments to one particular data set, bringing all these frameworks together. Back to you, Ram. Sorry for the transition.
Thanks. Yeah, thanks, Karthik. We just want to take the opportunity to see some of the latest technology advancements that we have in terms of AI and ML models, and how do we go about eliminating bias, or at least reducing it to a large extent. Any questions, Kim? Or Pinar, we can take those.
Wow, that's fascinating. We have probably time for 1 or 2 questions if there's any questions from our audience.
Well, it does none, but we would always want to make sure that we can share our email IDs and would love to work with the students over there.
Yeah, so Karthik, the last demo you showed was impact on the US data, or that was where I wasn't sure, like when you selected Italy, it was the impact of closing of Italian flights on the US?
Yes, that's
correct. Okay, very interesting. For the US data, I assume you were just using all the different case data from Johns Hopkins, and is that?
Yes.
Okay.
And, we have shared the details of the data sets we've taken from CDC, from NIH, and of course, from Johns Hopkins. And all the data sets and the links are available on the website. I would request my colleague Ram to share with you, Pinar. And thank you very much for the time, the opportunity to share something of value that you might really find.
Oh, thank you so much. And I believe this actually, there is one other question. Let me just take 1 more minute. The absolute change in bias in your first example did not seem great. Have you found significant impact in other work, is the question.
It makes a significant impact when we are actually looking at making sure that the training of the machine learning algorithm is going to be happening, say, for example, on a daily basis when we are looking at it from an industrial perspective. If you take it from a hospital to hospital perspective and say that, look, give me a patient population, I want to make sure that when we are kind of bringing in for all the providers, let's say Mercy, Scripps for any of the hospital, and apply the same thing over and over again, we have a better trained model, which is going to give you better accuracy and AUC rather than trying to do this over and over again. So we have a better trained model. That's what we're looking at. Want to share experiences? Would love to learn from you all. Thank you so much. It has been a fantastic session. Thank you, Pinar. We've been listening to everybody. I learned a lot. Thank you.
Thank you, Kim. I think we're ready to wrap up, I think. So we thank everyone for joining us on behalf of the 3 centers that have put together the symposium: Carlson School, the MISRC, Nursing School, Center for Health Informatics. We thank all the panelists and the questions coming in. And Kim, thank you so much for moderating for us. Have a very nice day, everyone.
Thank you, everyone.
Bye.
Thank you.